thyroid function test becomes very difficult to interpret. And nowadays, we are getting multiple reports of thyroid function tests because there are multiple panel tests which are being done. Patients are offered those tests. They come up with their report and it becomes very difficult to match with the clinical case scenarios as well as the thyroid function test. Sometimes you see that clinical picture does not correlate with the thyroid function test. And hence it becomes very difficult, especially to recognize those pitfalls. But if we fail to recognize them, it will not only lead to misdiagnosis, but also inappropriate management. Just a slight decrease in T4 will actually increase the TSH to multifold. And that's why you see those profiles of subclinical picture. That is when T4 is low, but you are finding that TSH is on a higher side. Biotin was stopped for 3 days. It got removed from the blood circulation and thyroid function test was repeated. Thyroid function test was found to be completely normal. So no treatment was actually required in this case. So this is the one case of assay interference where no treatment was required. So you have to always look that is there a correlation of clinical picture with thyroid function test or not. So thank you for that nice introduction. And I would like to thank Medflix to have given this opportunity to speak in front of wonderful audience. And I welcome all the doctors who have present here to learn about this thyroid function test. And I have made mainly this presentation in a case-based scenarios to make things interesting and more understandable. Generally, what we see that thyroid function test becomes very difficult to interpret. And nowadays, we are getting multiple reports of thyroid function tests because there are multiple panel tests which are being done. Patients are offered those tests. They come up with their report and it becomes very difficult to match with the clinical case scenarios as well as the thyroid function test. And hence, in general, if we just see that interpretation of those tests is generally straightforward. However, sometimes you see that clinical picture does not correlate with the thyroid function test. And hence it becomes very difficult, especially to recognize those pitfalls. But if we fail to recognize them, it will not only lead to misdiagnosis, but also inappropriate management. So just to understand our thyroid physiology, we might be able to understand our thyroid function test much better. As we all are well aware, just a recap of what things of physiology, hypothalamus release TRH, thyroid releasing hormone, which stimulates pituitary to release TSH. This TSH has a receptor over the thyroid, which stimulates thyroid gland to produce thyroxine. Mainly T4 is produced from the thyroid gland, and this T4 is converted to T3 by some deiodinase enzyme, which remove one iodine from T4 and make it T3. And this T3 is actually biologically active. There is a feedback inhibition from this T4, which inhibits the release of thyroid releasing hormone, and it decreases the TSH level. So this is what happens on normal physiology for thyroid hormone production. And then you find that there is a log linear relationship between T4 and TSH. In fact, just a slight decrease in T4 will actually increase the TSH to multifold. And that's why you see those profiles of subclinical picture. That is when T4 is low, but you are finding that TSH is on a higher side. That suggests sub-frank hypothyroidism. Another scenario will be where T4 is normal, but TSH is on higher side, and this is because of the log linear relationship of the T4 and TSH. To some decrease of T4, TSH will increase, and you will find subclinical hypothyroidism. Similarly, another profile could be when T4 is low, but T4 is high, and TSH is normal. That is subclinical hyperthyroidism. Next, T4 is high and TSH is also low. That is hyperthyroidism. Now, there can be multiple pitfalls where interpretation of thyroid function tests might become wrong. It could be at a level of pre-laboratory, that is, before the test going to the lab, if we have faced the difficulty in searching for the proper history, pregnancy changes, patient is pregnant where there is a lot of changes in thyroid function test, some thyroxine, patient is already on thyroxine therapy if we have not taken this history, or some medications which patient is on might interfere with the thyroid function test. Those medication history also need to be taken, plus non-thyroid illness. All these things which will be discussing in today's lecture. So pre-laboratory examination, clinical history is very important. If you pay insufficient attention, it might lead to TFT pitfall. Then at the level of lab, there is mainly assay interference. And in fact, post-laboratory, when the thyroid function test is available, there is a limited experience of interpreting that report, especially in rare scenarios, which is resistance to thyroid hormone or disorder of thyroid hormone transport or metabolism. In fact, TSS secreting adenomas are also being seen. So there is some rarer things which might not be known to physician, which again might lead to TFT pitfall. So this was a wonderful article which I am going to share, which will suggest what all pattern of TFT we can see. One is when the T4 is normal, TSH is normal. This is the patient with complete euthyroid picture, and T4 TSH is totally normal. Another profile can be seen where T4 is low and TSH is high. That is what we see in simple overt hypothyroidism. Similarly, T4 is high and TSH is low. That is overt hyperthyroidism. There could be multiple causes for hyperthyroidism and hypothyroidism. Not going into detail of these things because we have to deal with different scenarios, especially when you get the things like T4 is normal but TSH is low. That is subclinical hyperthyroid picture, or T4 is normal, TSH is high. That is subclinical hypothyroid picture. But in this, we can see multiple DDs also. Subclinical hypothyroid could be seen because of some drugs, malabsorption of thyroxine, even assay interference, and it could be just a recovery phase of non-thyroid illness. Similarly, subclinical hyperthyroid, you have to look for assay interference, non-thyroid illness, and some drugs like steroid, dopamine. All these things we are going to discuss. Another things which are still not that rare is when you are finding another profile of TFT, that is T4 is low, TSH is also low. So this is suggesting that patient is having central cause of decrease in the TSH. Next profile could be T4 is high and TSH is high. TDs of this again, low T4, low TSH is mainly pan hypopituitarism, or it could be because of non-thyroid illness. Another cause of high T4 and high TSH, mainly two DDs, the resistance to thyroid hormone and TSH secreting pituitary adenoma. But of course, drugs, non-thyroid illness, assay interference, all need to be also be ruled out. So from this background, we'll just start discussing different case scenarios to make things much more understandable. So this was a 45-year-old female patient which got admitted in my hospital for complaints of pain, abdomen and vomiting since 3 days. She had recurrent episode of those pain, abdomen and vomiting since past 5 years, and for which she required multiple hospitalization. If you just go on with the history, she was known hypothyroid and was on 75 microgram thyroxine. Patient gave history of premature menopause at 39 years, never started on oral contraceptive pills. Now she is 45 years old with recurrent episodes of pain abdomen and vomiting. So this was the patient. You can see the pale looking faces of this patient, and but hemoglobin you can see is normal. Liver kidney profile was normal. However, thyroid function test was offered because patient is known case of hypothyroid, was already on 75 microgram thyroxine. So this was the profile, and we should now have a deep look into the thyroid function test. So you can see that TSH is normal. Patient is on 75 microgram thyroxine. However, peculiar feature which could be seen is low T4. So T4 is quite low as compared to slightly lower TSH. This on the background of patient having recurrent vomiting, pain abdomen with premature menopause is suggesting of panhypopituitarism. So this is a case of central hypothyroidism or secondary hypothyroidism. So because we have to look for other hormones, she was checked with hormones FSH, LH, estradiol, all were found to be low. ATM cortisol was again found to be low. ACTH was done, which is not mentioned here, was found to be low. So this was 1.34, and hence she had hypocortisolemia, decrease in the estrogen hormone, because of which she had premature menopause plus hypothyroidism. So because of those low cortisol, she had recurrent episode of pain abdomen and vomiting. So this patient was given diagnosed as secondary hypothyroidism, secondary adrenal insufficiency, hypogonadotropic hypogonadism, that is panhypopituitarism. MRI was done, which was found to be have a normal pituitary gland. This patient was replaced first with steroid. Later on, thyroxine dose was actually increased from 75 to 125 based on her weight. Her T4 is mainly taken care of, and T4 need to be in a normal, mid normal to upper normal range in secondary hypothyroidism, and TSH should not be looked for. We have checked just for TSH in this case. We could have missed the diagnosis. And that's why role of T3 and T4 comes, especially in the first point of the patient. Once it comes to you, you have to order hold T3, T4, TSH to interpret whether which type of hypothyroidism patient is having. Now I will uh, just go on to the next case, and it is just a similar case as compared to case one with different diagnosis. This patient was 61-year-old male, looks older in ICU, type 2 diabetic, developed anterior wall MI, cardiogenic, and shock and atrial fibrillation. So now because he developed atrial fibrillation, there is no history of thyroid disorder. Still, because of AF thyroid function and shock thyroid function test was ordered. You can see the report. T3 is low, T4 is low, TSH is low. So what is it? Is it again central hypothyroidism? No, this is not the case in this scenario. There is no history suggesting of that. Patient is severely sick with shock. This causes one condition, what is called as euthyroid 6 syndrome, that is non-thyroid illness. What happened here is there is increase in the D3 activity, which causes inactivation of T3 to reverse T3 and T4 to reverse T3. So if you are going to check reverse T3, it will found to be quite high. However, T4 and T3 level will be lowered. Similarly, because of the increase in the cytokines interferon, TSH level also reduces. So you find all things to be low, T3, T4, TSH. So in ICU settings, you will find the patient's profile similar to central hypothyroidism, but here thyroid hormone replacement is actually not recommended. In the case 1, we have replaced the thyroxine along with steroid, but in this case 2, in euthyroid 6 syndrome, it is not recommended to replace thyroid hormone. because it is been found to have just an intrinsic abnormality of hypothalamic pituitary thyroid axis. So it is just a secondary adaptive change which will automatically improve once the patient recovers from that serious illness. No need to know of treatment, and there were studies which were done. There was no improvement of change in the mortality or morbidity or ICU admission if you are replacing those patients with thyroid hormone. So these were the two conditions where central hypothyroidism and non-thyroid illness, where if we have done just TSH, we could have actually missed the diagnosis. In non-thyroid illness, if we have checked that TSH was low, we could have considered him as a hypothyroid and have started on hypothyroid treatment. And this patient with central hypothyroidism, if we have did not done T4, we could have missed the diagnosis that patient was having central hypothyroidism. Similarly, we can see another two main conditions where this diagnosis can again be misleading if you have just done the TSH at the first point of patient contact. This is resistance to thyroid hormone and TSH secreting pituitary adenoma. I have one case scenario which will be dealing with these scenarios later on. Now, coming forward, now we also see a lot of challenging thyroid function tests nowadays because of the interferences in the immunoassays. Immunoassays are generally the method of choice for measurement of thyroid function test, but it might lead to interference in the reports which are not correlating with the clinical profile, and many don't need any treatment. It is just a lab error because of the interferences in the assays which are used in the lab. So there could be multiple interferences, especially in thyroid function test. Most common is heterophilic antibodies. Biotin is not uncommon nowadays. Now also we can see some problems like macro TSH, thyroid hormone autoantibody, ruthenium or anti-streptavidin antibodies. So with this interference, I have one case scenario. This was the patient, 63-year-old woman with past history of Graves' disease, and she underwent radioactive iodine ablation. Since then, she was euthyroid. So because she underwent radioactive iodine ablation, there is a risk of reactivation of Graves' disease. She generally checked her 6-monthly thyroid function profile test, and this time it came out that T4 was found to be on higher side and TSH was found to be on lower side, suggesting that it is a reactivation of thyroid Graves' disease, and we might need to start her on anti-thyroid drugs. So this patient was referred to me for the further management. But when she came, we find that there is no goiter and there were no symptoms which were suggestive of hyperthyroidism, no clinical features or tremors. So there was a clear cut, we can think of that there is a clear cut discrepancy between clinical picture as well as thyroid function test in this case scenario. So of course we have to dig further that what happens, why there is a discrepancy. Now on detailed history, she was found to have giving the history of hair loss since menopause and was on dermatologist treatment, and her dermatologist was given her a biotin dose of 10 milligram per day since 9 months, 3 months. So biotin per se, as we have discussed in one of the interference, gives you a lot of interference in thyroid function test. Why it is so? Because those immunoassays which are being done, they are actually using the antibodies labeled with biotin. So if the patient is on high dose of biotin, it will saturate those streptavidin fixed solid supports, and because of this, there is no binding of the sandwich acid, because of which you will find low TSH level. Similarly, T4 and T3 again will found to be on higher side. So in these scenarios, biotin was stopped for 3 days. It got removed from the blood circulation and thyroid function test was repeated. Thyroid function test was found to be completely normal. So no treatment was actually required in this case. So this is the one case of assay interference where no treatment was required. Just so you have to always look that is there a correlation of clinical picture with thyroid function test or not. Next was a case of 24-year-old female with Hashimoto thyroiditis. She's overt hypothyroid. First TSH was more than 100. Weight is 60 kg. So ideal dose would be around 1.6 to 2 microgram per kg. That is around 100 to 120. But she was on 150 microgram thyroxine. Patient's TSH level, when checked on Siemens detection system, was found to be still 60. So what should be done? We have to increase, ideally, we have to increase the dose of thyroxine to either 175 or 200. But clinically, if you see, patient was actually complaining of multiple episodes of palpitation, hyperhidrosis, and fatigability. That is, biochemically, she is hypothyroid, but clinically, she is hyperthyroid. So the patient was just asked to repeat with a different lab, and it was Beckman-Coulter. TSH came out to be less than 0.01, which was actually correlating with the clinical picture. So one lab was saying 60, one less than 0.01. So why there was a discrepancy? So most commonly, discrepancy would be mainly because of heterophilic antibody interference, which is not uncommon, and it might lead to falsely elevated level of TSH. So in this case, we have not taken TSH as a marker, but T4 levothyroxine replacement was just at a dose done at a dose of 1.6 microgram per kg per day, and free thyroxine level was used for subsequent dose adjustment. So how to neutralize the human heterophilic antibody? You can either repeat the test with a different assay, which we have done, or you can ask your pathologist to use a heterophile blocking reagents or do a serial dilution. These things could be done to skip the effect of heterophilic blocking agents. Gold standard is equilibrium dialysis method, which is in general not very much available in routine labs. So these are some assay interferences which could be seen in our patients. Next could be some drugs which are altering the thyroid function test. So before interpreting any thyroid function test, we should be aware that patient is not on those drugs, because these again can alter your thyroid test. Such drugs, commonly used drugs, especially in ICU, you can see patient is on dopamine, glucocorticoid. They can directly inhibit the release of TSH. Next, some drugs will directly act at the level of thyroid hormone. Amiodarone, you can see both effects. It could cause hypo or hyperthyroid. Lithium mainly causes hypothyroid. Iodine effect is similar to amiodarone. Again, you might have both the effects. Some drugs like tyrosine kinase inhibitor, TNF-alpha, all can inhibit the thyroid hormone secretion. There could be decrease in the thyroxine absorption, especially the patient with hypothyroid. You might need to tell them that these drugs might interfere with your absorption. So ideally, these drugs to be taken 4 hours after thyroxine supplementation. That is calcium, iron, antacid, sucralfate, all can interfere. Some drugs alter the transport of thyroxines, and that might estrogens, patient is on OCPs, it might increase the thyroid binding globulin. You will find high T4 level. Androgen or glucocorticoid, on the other hand, might decrease the TBG, and you might find lower T4 level, especially the total T4 level. Some drugs will displace thyroid hormone from the binding protein, mainly the thyroid binding globulin. So you will find higher free T4 levels. It could be seen in patients on heparin, furosemide, even anti-epileptics, phenytoin, carbamazepine. Some drugs increase the hepatic metabolism, so you might increase the turnover, you might need higher doses, and some decreases the deiodinase activity, like amiodarone, beta blockers, steroid, PTU. In fact, this has been utilized to treat the thyroid storm, and that's why propyl thiouracil is still used as a first line, might be used even in thyroid storm. So this, coming to the drugs, another case 5. This was a 77-year-old female, hypertension, known case of hypertension, but she had a fall followed by fracture right neck femur. Post-operative, she was operated for fracture. Post-operatively, She developed atrial fibrillation, was given heparin. She was euthyroid, no goiter, but atrial fibrillation. Now she is on a control rate 110 per minute because she developed AF. Thyroid function tests were ordered. So thyroid function test showed T4 high, TSH abnormally on a lower side as compared to T4. So what is it? Is it a patient of hyperthyroid? Do we need to start with antithyroid drugs like carbimazole or methimazole? So one could be one case scenario. Another could be drug effect, and really it could be because of TSH secretory pituitary adenoma. And plus we need to take the patient history. Patient might be started on thyroxine because of which T4 is normal on higher side and TSH is on a lower side. So this was the patient. If you just go and dig the history, patient was given heparin. And as we have discussed, heparin will actually can cause displacement of thyroid hormone from their binding site, mainly because of the heparin induced increase in the free fatty acid level. And because of which you found that free T4 was on higher side and TSH was on a normal side. So in this case scenario, TFT was reassessed one day after heparin injection. T3, T4, TSH was found to be completely normal. So of course, again, in this scenarios, no treatment was required and thyroid function test alteration was mainly because of heparin injection. So one thing which has to be looked for in this case again was patient, those profile was showing hyperthyroid, atrial fibrillation, but patient didn't have any history of goiter, tremors, no hyperthyroid symptoms other than atrial fibrillation. So this, in this case scenarios, we need to take much more histories that what could be the altering factors which are causing altered thyroid function test. So last case, uh, this was a 13-year-old boy referred for neck swelling since 2 months, but no symptoms of thyrotoxicosis. Patient had grade 2 goiter. So 13-year-old boy with a goiter, his thyroid function test was done. T3, T4 is high, TSH is normal. So this patient is, of course, having a rare problem. That is a goiter with T4 is high. So is it a case of hyperthyroidism? Do we need to start with anti-thyroid drug? But patient had no symptoms of thyrotoxicosis. So this patient is actually going into mainly into two DDs. Either it could be TSS secreting pituitary tumors or it could be resistance to thyroid hormone. So this was a case of resistance to thyroid hormone. What happened in this? There is mainly a receptor mutation at the level of thyroid receptor beta gene. This is the pituitary level thyroid hormone resistance, because of which you get lesser feedback inhibition of TSH. So T4, T3 becomes higher. In spite of that, TSH is not higher. Patient is generally euthyroid, and only lesser 15% are actually hyperthyroid and need to be treated with beta blockers. So euthyroid patient can be left alone without any treatment, and this was done in our case. So just to differentiate between TSH secreting pituitary tumors and resistance to thyroid hormone, you need a MRI. MRI will be showing a pituitary adenoma in TSH secreting pituitary tumor. You will find higher sex hormone binding globulin plus strong family history with the first degree relative in resistance to thyroid hormone. So this is again a rare case scenarios, but we do still find these case scenarios. So in short, if we just get a discordant TFT, this is a very beautiful flow chart which need to be followed. So first you have, if you find discordant TFT, you have to re-evaluate the clinical history. You see the age of the patient, elderly patients, obese patients, pregnancy changes could be there because of mainly because of the increase in the thyroid binding globulin. You have to ask the patient is not on thyroxine therapy. Some medications, as we have discussed, like heparin, steroids, dopamine, amiodarone, multiple drugs can interfere. So you have to take those medication history, non-thyroid illness also to be looked for. So once all these history has been taken care of, you reassess the thyroid status, whether patient is hypothyroid, euthyroid, hyperthyroid. And down if you are finding still the TFT is discordant, you have to look for thyroid hormone interference or TSH interference, Assay interference. Again, if that has been ruled out, then you have to look for rare causes like TSH secreting pituitary adenoma or resistance to thyroid hormone. So mainly, my presentation has major take-home message. That is, one is only TSH can give you wrong interpretation, and hence you should always ask for full thyroid function T3, T4, TSH at least on the first visit. And now, if you find that patient is hypothyroid, you just ask for TSH level. That will be done. But for the first visit, you should always ask for full thyroid function test. Otherwise, you are going to miss the cases like central hypothyroidism, non-thyroid illness, resistance to thyroid hormone, TSH secreting pituitary adenoma. All these diagnoses can be missed. So once it has been done, you should always have a proper history, elicit the drugs which actually can alter the thyroid function test. Then also suspect, especially in severely ill patient, it could be a case of 6U thyroid syndrome. After that, if you are finding that still it is a discordant TFT, that is, clinical picture is not correlating with your thyroid function test, Assay interferences should always be ruled out, and then at the last should consider the rare DDs of thyroid hormone resistance or TSS secreting pituitary adenoma. So with that, I will end my discussion topic. Any questions or queries are most welcome.
Yes, sir. We have a few questions in the comment section. I will ask them one by one. We have a question by Dr. Vinay. Is neomertazole or methimazole, which is better, and how long it should be given in uncontrolled hyperthyroidism?
So there is no difference between neomertazole or methimazole. Both are found to be safe. We do use different drugs. Especially we find if there is an allergy to one drug, another drug could be used. So both are found to be equally effective, but there is a dose difference. That methimazole 7.5 mg will be equivalent to 10 mg of carbimazole. So ideally, hyperthyroid patients need to be treated at least for 2 to 3 years, and then only we have to taper the dose, and after that we can stop the drugs. Though there are multiple studies which are coming in elderlies now, there are studies that we can continue to give low dose anti-thyroid drugs in the long run also. So ideally speaking, generally 2 to 3 years is the time till which we tend to give the anti-thyroid drugs, taper it off, and then stop.
Yes, sir. So continuing this question on methimazole, what is the safety of methimazole in first trimester?
Yes. Again, if you go with methimazole, is generally found to be safe. There is very less side effects, very less congenital defects which are being seen. But still, now American Thyroid Association guidelines, they still recommend that propyl thiouracil should be used till 15 weeks, and later on, from the 16-week order onward, you can start with methimazole or carbimazole. So at present, methimazole should not be used in first trimester because it do have some congenital defects, and in fact, this is only one indication for propyl thiouracil where it has to be used till 15 weeks of gestation.
Yes, sir. We have a question here by Dr. Ravindra Kulkarni. Which is the ideal test for early diagnosis of thyroid malignancy?
Thyroid malignancy, ultrasound is the only thing which we need to do. And if we find, we generally grade those malignancy from the ultrasound. We have a scoring like Tirard scoring. If it is more than Tirard 4 and 5 is more suggestive of malignancy. If there is involvement of lymph nodes on ultrasound, again, it is more suggestive of malignancy. So we generally do a FNAC or biopsy. If it is confirmed, only then we go on for treatment. So there is no blood test which can actually tell that patient have malignancy or not. This is mainly a ultrasound based diagnosis followed by FNAC. So once if we find it to be not to be very benign lesion, or if it is increasing after 6 months or 1 year, you repeat it ultrasound, it is increasing to more than 20%. This is again a suggestive of some might be because of malignant condition. So we have to decide accordingly that whether this patient has have a malignant thyroid nodule or not. Only then we go on with the surgery. 90% of the thyroid nodules, in fact, 95% of thyroid nodules are actually benign and should not be operated.
Okay, sir. Thank you. We have a question here by Dr. Satish Patel. A patient has subclinical hypothyroidism where TSH is 19, but T3 and T4 is normal. The symptoms indicate that the patient is converting from subclinical hypothyroidism to clinical hypothyroidism. Is there any chance of normal thyroid function from subclinical hypothyroidism?
For subclinical hypothyroidism, there are some guidelines that when to treat, when not to treat. You have to look for an anti-TPO level. Generally, if TSH is more than 10, ideally we need treatment because there is a high risk of CV mortality and morbidity. So there, treatment is indicated. So in subclinical, you have to look for the other symptoms also, like patient is having symptomatic problems, menses irregularity, patient is planning for pregnancy, patient is having goiter, or anti-TPO positivity. Anything is present, you have to treat. But in this case, I could see that TSH is more than 19, more than 10. Anyways, we might need to treat the patient, provided we have ruled the other conditions also. It could be a case where patients have on biotin, as I have discussed in one case, where you might find higher TSH, Assay interferences could be one thing. So these all need to be ruled out.
Yes. So, a question by Dr. Satish Patel again. What lifestyle and dietary changes are required for subclinical hypothyroidism patient?
Again, this is a very common question, and I would say a common myth also, that dietary changes might improve your thyroid function. And these are from the even the American Thyroid Association guidelines, which we as an endocrinologist generally follow. There is no such dietary restriction. We say that cabbage, broccoli, these are actually might interfere with your thyroid profile, but it is actually not being seen. This is just a problem. Why? Because cabbage and broccoli, cruciferous vegetables, all have found to have a thyroid extract, which might actually have some role in the altering your thyroid function. But it is only when you are taking daily. If you are taking it, cabbage and at the breakfast, lunch, dinner, only then it is going to interfere. So ideally, these all things are not to be restricted in our patients. They can take. Similarly, gluten diets, I see some patients, they are stopped with taking gluten diet. Again, this have no impact on thyroid function test. So there is no dietary restriction, there is no exercise, there is no meditation which can actually improve your hypothyroid profile. So there is nothing which we can offer. Only thing is, I would just like to highlight once this question has come up, that subclinical hypothyroidism is not diagnosed with the one test. So what is the actual definition? That even after 2 to 3 months, the TSH is still the same or in an increasing trend. Only then you will say that patient is having subclinical hypothyroidism. Because many of them could be could automatically recover. Like patient was on biotin, patient was on a recovery stage of non-thyroid illness. There again, TSH might be high. It can automatically revert back to normal. So these things are being seen. So with one TSH high, T4 normal, you cannot diagnose subclinical hypothyroidism. You have to wait for at least 2 to 3 months, repeat the thyroid function test, and again, if you are finding it to be on a higher side, only then you will say that patient is having a subclinical hypothyroid. and only then you are going to decide whether to treat or not to treat.
We have questions here by Dr. Kamani. Is when to check free T3 and free T4 instead of T3 and T4?
In general, what ATA also recommends that total T3 T4 could be all done in most of the scenarios. Only in rare scenarios do we ask free T4 free T3. This is especially in case with pregnancy, patient is on oral contraceptive pills, steroids, androgens, because they might alter the thyroid binding globulin. So again, in those scenarios, we might need to order free T4, free T3. Some case scenarios, you are thinking that there might be a altered thyroid profile function. So some cases, we might need to reorder free T4 just to cross check that T4 is right or not. So mainly most of the thyroid function test could be diagnosed only with total T3, T4 and TSH, and there's not much need of free T3, free T4 and TSH.
Okay. So one question similar by Dr. Sunita is should TFT be done fasting?
Yes, this is again this thing was commonly done before when the assays were not that great, but now we can do fasting, even non-fasting. Thyroid function could be done. There is not such problems, so it is not necessary. So only thing which has to be taken care is if you are doing a T4 level also. For TS, this is about for the TSH. If we are also checking a T4 level, ideally patient should be skipping the dose of thyroxine, because if the patient has taken thyroxine tablet and given T4 as well as TSH, T4 might be increased by 20 to 30% because of that thyroxine tablet. So ideally, thyroxine should be skipped on the day of test only if you are doing a T4. But if you have ordered just a TSH, there is no need for skipping even the thyroxine dose.
Okay. Uh, there is one question by Dr. Dinesh about is vitamin B12 and vitamin D3 deficiency common in hypothyroidism?
There is a correlation which has been seen, but it is not proven. So we need multiple studies for that. So it's not like because of thyroid, vitamin D and B12 is deficient. So we don't have much studies for that.
Okay, so continuing to the previous question, there is Dr. Parvati is asking, uh, diurnal variation is there for TSH. Hence, what is the ideal time to test the thyroid function?
Yes, ideal time would be because most of the essays which we have derived is from the morning. So ideal time would be a morning time. Evening, you might find increase in the TSH. That is very slight, but best time, if I say, it should be done in the morning. But it becomes very difficult in our OPD sometimes to do a morning test because patient is coming from outside. You are coming from far away. You are asking them to do a fasting morning sample. Patient has to wait just for the thyroid test. But we do generally do even in the evening, interpret it accordingly. But if you ask me what is the best time, it is morning.
Dr. Nandita is asking how often do TFT is to be repeated in hypothyroidism, which is well controlled on drugs?
So again, if I just quote the ATA, American Thyroid Association guidelines, we generally, once we start treating hypothyroidism, you ask the patient to do its repeat thyroid function test after 6 weeks. And why it is 6 weeks? Because it requires 6 T half-life of thyroxine tablet to get the TSS to be normal. So after 6 weeks, we generally ask for the thyroid function test. So once the thyroid function test becomes normal, we keep on increasing the interval. We increase it from 6 weeks to 2 months to 3 months and then 6 months. And then 3 to 6 monthly, we need to recheck. Always have to recheck lifelong. So this is the time where we have to do monitoring of the thyroid function test.
Dr. Mahesh Mittal is asking, in autoimmune thyroiditis, which is more specific? Is it anti-TPO or thyroglobulin antibodies?
autoimmune thyroiditis, NT-TPO is the most specific and recommended. It's not ATG. Ideally, is being not being done. NT-TPO is more specific and sensitive. 95% of the cases you might find high NT-TPO. Some case scenarios, there are very rare case scenarios, in fact, where you will find NT-TPO to be negative and ATG to be positive. So we generally ask for NT-TPO and not ATG.
Okay, sir. There is a question about interpretations of TFTs in pregnancy, and
Yes. Yeah. In pregnancy, it becomes very difficult especially to diagnose thyroid function tests. We do see different case profiles. So if the patient's generally total T3, T4 might be high in pregnancy, and TSH will be normal. So this is the case. Why? Because there is a higher thyroid binding globulin, which increases the total T3 and total T4 level. So in those scenarios, we might need to ask for the free T3 and free T4 level. Then you do also see, especially in the first trimester, that TSH you can find it to be on a lower side, that is 0.1, 0.2, and T3, T4 is normal or slightly on higher side. So this could be just a case of gestational, transient gestational hyperthyroidism. This is just because HCG mimics your TSH value, TSH, and as the HCG increases in the first trimester, it reduces the TSH level and increases the T3, T4 level. So HCG acts at the level of thyroid to increase the thyroid hormones, which gives a negative feedback to pituitary and reduces the TSH level. So this again conditions becomes automatically will become normal by 15 weeks to 20 weeks, totally normal by 20 weeks. So this is a transient gestational hyperthyroidism, again need not to be treated. So one case scenario, total T4, T3 could be high because of high TBG, and another could be TSH could be low because of transient gestational hyperthyroidism. So in fact, thyroid hormone turnover is also increased in pregnancy. So all these things are being seen because of the increased metabolism.
sir, we have a question by Dr. Rajendra. What is the therapeutic dose of radioactive iodine therapy for Graves' disease?
No, this actually has to be decided uh, by nuclear medicine specialists based on the weight, thyroid gland. They all decide and accordingly they give treatment. So there's no fixed dose, and there are formulas which has to be used, and accordingly their dose has been decided.
Uh, Dr. Arun is asking, what is the effect of obesity and on the values of TFT?
Right. And again, this is actually very important and interesting question. We do see patients in OPD who are obese with a weight BMI of more than 30. They generally get the thyroid function test. Why? Because they want that whether thyroid is not the cause of their obesity. So we do get TSH of 6, 7 in those case scenarios. When they come to an our OPD, that this is because of hypothyroidism, I am getting obesity. But actual case scenario is not because of hypothyroidism. This is actually because of obesity. You are getting a subclinical hypothyroid picture. And that is because there is an increase in the leptin in the patient who are obese, which actually increases the TSH level. So these patients need not to be treated. So I will just repeat, these patients need not to be treated. The obese patients whose TSH level is higher, they actually have to be monitored. And once the weight reduces, most of them TSH will become normalized. We do need to rule out the specific symptoms if they are not present, anti-TPO status. If all these things are negative, 90% of them don't need any treatment. So you just have to tell them, counsel them that this is because of a higher obesity level, weight level, and not because of the hypothyroidism. So this obesity is not because of hypothyroidism, but it is vice versa. Because of obesity, you are getting altered thyroid function test.
So there are a couple of questions about usage of selenium supplements.
So selenium has been found to be useful in thyroid disorders in general, but we don't have multiple studies, especially in Graves' disease, Graves' eye disease, thyroid ophthalmopathy, where selenium has been found, especially in the early stages. Otherwise, overall, selenium usage has been found to be quite controversial. Some studies are suggesting it might be useful overall in thyroid health, but if the patient develops frank hyperthyroid, none of those selenium supplementation can be helpful. You have to offer them only anti-thyroid drug or thyroxine.
We have a question by Dr. Harini Reddy. When thyroid hormone replacement involves alternating daily doses, what is the optimal approach to the dose adjustment? Should clinicians rely on average weekly dosing or use a weight-based calculation?
I would say that weekly dosing we rarely used. Why? Because weekly dosing means once a week if you are giving thyroxine, you have to, like patient is on 100 microgram thyroxine, you are giving 700 microgram on Sundays for let's say. So that will increase the symptoms level initially once that 700 microgram thyroxine is given, and patient will have lot of palpitation. So it is you will use very rarely. So ideally, best thing is to be used is with a weight based calculation, and that is why we generally, as an endocrinologist, we generally use that we divide our doses. That if the patient is of weight of, for say, 64, and if you multiply it with 1.6, ideal dose might be coming in the range of like 105. So how to give 105? 105 is not available in market. So we do divide that. Give 100 6 days in a week and 125 one day. So you might get an optimal thyroxine dosage. So this is a commonly used thing which we do in our clinical practice. Patient are found to be also being okay with this method in general.
Yes. So we have a question by Dr. Mariam. Is there any correlation of thyroid with hypertension?
Thyroid per se can cause hypertension. Hypo and hyperthyroid both can cause. Especially hyperthyroid can cause systolic hypertension, and hypothyroid can cause diastolic hypertension.
Okay. We have a similar question about in PCOD as well. Yes. So in PCOD, high TSH levels are to be considered initially, or to be evaluated after treating obesity and PCOD, or repeat tests intermittently and take accordingly.
Hypothyroid, if it is found in PCOD, we generally treat because that might improve the menstrual flow, menstrual cycles. Irregularity might be improved. So, patient is infertile couple, planning pregnancy, PCOD patients, and ovulation. All these are the strong markers that we should be treating subclinical hypothyroid. So obese patient, PCOD, you have to treat. Obese patient, not PCOD, you have to rethink whether we have to start treatment or not.
Okay, so to summarize the entire talk, can we have one last question on what are the management do's and don'ts and interpretations of TFTs that we can remember?
If I just summarize my talk, which I have in fact highlighted in my summary also, that only TSH, if you are checking, you might miss the diagnosis. So on the first visit, you should always check for full dose of full T3, T4, TSH, and only then interpret. Also, while interpreting thyroid function test, you have to look for other confounding factors like patient's age, pregnancy, patient is what drugs patient is on, because they might alter your thyroid function test, pregnancy status. You also have to ask that patient is not on thyroxine. Patient might not tell you that patient is taking thyroxine, So there could be factitious cases where you might find that patient was taking thyroxine. This is also been seen in clinical case scenarios. So once you are finding discordance, and also have to look for the symptoms of hypothyroidism, and then only check the thyroid function. Don't just see the report and go on treating accordingly, and then it will lead you and your patient to a pit. And these are the pitfalls which are to be taken into consideration. Thank you.
Thank you so much, sir. I think more or less all the questions have been answered in this session. Thank you so much for joining us today, and I like making this session a very interactive session as well, and answering so many questions from our audience.
Thank you for inviting Dr. Sakuni. And thank you, audience, for all that questions. Thank you, doctors.